Good evening. Welcome and thank you for attending our Head of Cancer lecture series sponsored by the Allegheny Health Network Cancer Institute. My name is Margie Leslie and I'm one of the directors here at the Cancer Institute. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the Q&A portion of the Zoom. We'll be addressing those questions at the end of the lecture if time allows. Participants aren't able to speak during the conference, but again, we encourage feedback via the Q&A option. Tonight, we're excited to welcome Dr. Tom Colonias, Dr. Zach Horne, and Dr. Paul Renz for our topic tonight, Radiating Cancer, the Latest Technology. Dr. Colonias completed his undergraduate degree from Duquesne University in 1996 and graduated from Northeastern Ohio University College of Medicine in 1996, pardon me. He completed an internship at Mercy Hospital, Pittsburgh, and subsequently completed 4 years of residency training at Allegheny General Hospital. In 2001, he was named an attending radiation oncologist at Allegheny General Hospital. He is highly skilled in the use of stereotactic radiosurgery and intensity modulated radiation therapy and has a special interest in treating chronic thoracic malignancies. Dr. Colonias holds numerous leadership positions, including Director of Radiation Oncology Clinical Practice and Vice Chair of the AHN IRB. He also has a strong interest in clinical research, presenting at national and international meetings, and publishing several manuscripts. Dr. Colonias is board certified by the American Board of Radiology and Radiation Oncology. He is a member of the American College of Radiation Oncology, American College of Radiology, American Medical Association, Society for Therapeutic Radiology and Oncology, and the American Society of Clinical Oncology. His presentation will be followed by Dr. Zachary Horne, who is a radiation oncologist at West Penn Hospital. His focus on gynecologic malignancies, including cervical cancer, and provides brachytherapy to many patients at Allegheny Health Network. His research interests include closing disparity gaps in patient care, especially in the underserved and marginalized patient populations. Dr. Horne received his medical degree from George Washington University School of Medicine and completed his residency at the University of Pittsburgh Medical Center. He is board certified by the American Board of Radiology. When he's not at work, he can either be found on his bike or in the kitchen cooking dinner with his friends and family if he's not exploring the world with his partner, Maya. The next speaker will be Dr. Paula Renz, is a radiation oncologist at Allegheny General Hospital, as well as Jefferson Hospital. He is a graduate of Lake Erie College of Osteopathic Medicine. Dr. Renz completed his residency at Allegheny Western Penn Medical Education Consortium, and he is board certified by the American Board of Radiology, Radiation Oncology. I'd like to welcome Drs. Colonias, Dr. Horne, and Dr. Renz, and I'll hand it over to Dr. Colonias to begin this evening. Thank you.
Thank you, Margie. I'm just going to get my slides up. Let's see. And hopefully you guys can see my slides.
Yes, we can. It's just not in presenter mode yet, but we can see it.
Let's see if we can get it in presenter mode. How's that?
No, I would go slideshow at the top. If I record.
Yeah, I did. I have two monitors. So.
Okay, that's fine. This will work.
All right. Sorry about that.
See it. Yeah, no worries.
So I'm really just going to give a general introduction about some of the advancing techniques that we use in radiation oncology and kind of go over an evolution of where our field has gone. And then I'm going to kind of go over a case and I do lung cancer, so it's going to be a lung cancer case. So busy slide, but really I just wanted to kind of give an idea of the history of how we evolved in radiation oncology. In the 70s and 80s, we used to do radiation with a technique called two-dimensional radiation. And basically it was...
we currently see your title slide. My apologies.
Oh, really? So let me how about now?
Yeah, if you stop that presentation and then you might have to share your other screen because you have two screens going there.
Yeah, I don't know how to do that, so we'll just continue this way.
Okay, we're on slide 2 now. Very good.
Right. So this is getting back the evolution of radiation. two-dimensional radiation is the old way of delivering radiation, and basically it's based off of X-rays. You design a field based on an X-ray, and you treat the tissues through that X-ray. It delivered radiation to where we wanted to go, but it also treated a lot of unnecessary tissues. In the 80s and 90s, we developed 3D conformal radiation, which is CAT scan-based radiation treatment planning. And it allows us to reconstruct the patient in 3 dimensions. It allows us to see exactly where the tumor is and monitor dose of the tumor in the normal tissues. So this technique really allowed us to be a lot more conformal with how we deliver radiation into the body. And then from 3D conformal, what we use now is called IMRT. It's intensity modulated radiation. And there's advanced techniques of IMRT called VMAT, and I'll get into SABRE, which is stereotactic treatment. But really, IMRT is a further enhancement of 3D conformal radiation. And I have some pictures that kind of show the process. So the process for radiation is, it requires a planning process, which the first step is to try to immobilize the patient, whether we put them in some kind of beanbag or some kind of mask system, so that every day when we treat them, they don't move and we can recreate that position. Then we do some type of imaging study, and usually it's a CAT scan, and that's in the treatment position. And then the patient usually goes home, and then we do a lot of behind the scenes work where we do all the calculations, and then the patient comes back and we do treatment. So the next slide basically is an X-ray of a patient. This is the lung here in black, the lung on this side, the heart silhouette is right here. And there's widening of the center of the chest here caused from a tumor. So when we used to do conventional radiation, we would basically get this X-ray and basically define an area where we treated with radiation inside this box. So everything inside this box got full dose. That includes the tumor, but it also includes normal tissues. Whenever we actually superimpose the actual tumor on this X-ray, when we do CAT scans, the purple and red signify the tumor. If we did it the old way, we would be treating the tumor, not missing, but we would be treating a lot of normal tissue. But in this area here, we may be missing a little bit of the lymph nodes. So this technique was good for its day, but since then we've gotten a lot better. This is just another example of conventional treatment. Basically, a beam comes in front of the patient from the front and from the back, and all the tissue inside of it is basically getting full dose. The lung sits here getting more dose than we want it, the lung on this side too, and then the heart gets a lot of dose. The tumor's right here, mind you, so we want to treat this area, but we're treating a lot of normal tissue to get to this area. So 3D conformal basically allows us to kind of bend the dose of radiation, just treat where the tumor is and not treat a lot of the normal tissue. The heart is right here, the lung sits here. That other picture showed us blasting through the heart and the lung. With this type of technique, we do not. And then with IMRT, it's even that much more conformal. So a couple more pictures. This is 3D conformal radiation. And again, this is the front of the patient. This is the back of the patient. The tumor is right here. It's esophageal cancer. The heart sits right here. The lungs sit right here. With 3D conformal radiation, we're treating with beams, with angled beams, allowing us to treat the tumor, not treating a lot of the heart, but still getting some of the heart. So all these tissues inside these blue lines are getting significant doses of radiation with 3D conformal. When we use IMRT, you can see that it's even that much more conformal. The doses of radiation are sparing the heart, sparing a lot of the normal lungs. We're still treating the tumor to the dose that we want to, but the dose of the normal tissues is significantly less. Again, just an example of old technique with APPA fields, meaning fields coming from the front and the back. Everything is getting full dose, including the heart and a lot of the lungs. 3D conformal is an improvement. You can see that the heart is getting spared here. Some of the lung is getting spared, but it's still getting some treatment of the lung and of the heart. And then with IMRT, you can see there's further sparing of the normal lung and of the heart. So IMRT is what we use for definitive cases, and this is actually an older IMRT technique. We're even better than this with modern techniques. So the next part of my talk, I just want to talk a little bit about a technique called stereotactic body radiotherapy. It's also called SABR, and that's probably the sexier name, stereotactic ablative radiation. So what is this? It's basically a way to deliver high dose radiation to a limited volume very precisely. We usually do it in 1 to 5 treatments, and really that's been a paradigm shift in our field over the last maybe 15 years. Most patients, 15, 20 years ago would get 5 to 6 to 7 weeks of daily radiation, where we would give small doses every day and spread it over time. One of the reasons why we would do that is because of the large fields that we had to treat and the result in potential side effects. We couldn't give the radiation quicker, or we would have a lot of side effects. But with the advancement of all these techniques, we can be very conformal and allowing us to treat a very small area. So the dose of radiation we can deliver a lot faster. So what we would do in 6 weeks of treatment, 20 years ago, now we can do in 5 days. So we can deliver 50 gray of radiation in 5 days versus 50 gray in 5 weeks. And that's basically due to these techniques that allow us to be that conformal. So what can we treat this technique with? What types of cancer, what disease sites? Well, really various disease sites throughout the body, including brain, including lung, including prostate, cancer involving the bone in the right situation, adrenal gland, kidney, and the list goes on and on. I believe Dr. Renz is going to talk a little bit also about stereotactic treatments on the MR-Linac coming up. So again, that process that we use for radiation includes some type of immobilization, and I'll show you that with the case. Then we do a planning scan. Then we do a lot of treatment planning behind the scenes, and then treatment delivery. And one thing that I want to add is this process is not driven by just one person, the physician. This is driven by a team of staff that work together. We have therapists that help with the simulation. We have planners or dosimetrists that help with the planning. We have physicists that verify everything and make sure that the dosing and everything is safe. And then we have therapists again who deliver the treatment. So it's really a team, behind the scenes team approach that makes us successful. So this is immobilization. Basically, this is a bean bag that we suck the air out, and it conforms to the patient's body. And then when we treat the patient, we put them in this bean bag every day for treatment so that we can set up that same position every day precisely. So once we make this bean bag mold, we do a special CAT scan. And this is the planning CAT scan. This is just one slice through the patient of this CAT scan. And just to orient everybody, it's a zoomed in CAT scan, but this is the patient's chest or front here. This is her back. The black is the lung, and this is the right lung. You can see that should be a left lung on this side, but this patient had a pneumonectomy, removal of her left lung, maybe 3 or 4 years prior to this. So we were watching her with scans every so often, and she popped up this nodule here in the right lung, which we biopsied, and then turned out to be a second lung cancer. She had her first one treated with surgery years ago. But because she already had extensive lung surgery and her lungs were not the strongest, she was not a candidate for further surgery. So she saw me, and we opted to treat her with stereotactic treatment. And then this is the nodule that we treated. So the next slide shows the actual radiation plan that we delivered on her. And, these slides are a little confusing, but just the red represents the tumor. And that yellow line that you see, everything inside of that yellow line represents the full dose of radiation that we delivered. So the tumor got the full dose. And these other lines outside of that yellow line indicate lesser doses of radiation. And this is the striking view from the side. You can see that the full dose was where the yellow is, but you can see that this blue line is very limited dose of radiation and sparing a lot of the normal lung. The key with this patient is obviously we want to cure her this cancer, but we also want to make sure that we don't cause a lot of damage to normal lung and cause her having a lot of breathing problems, etc. And this technique allows us to deliver high dose precise radiation to the tumor with limited dose to the normal tissue. So how did she do? Well, we delivered 4 treatments, a total dose of almost 5,000 centigrade. At about a month out, she was doing fine from a breathing standpoint. No changes in her breathing, but she did have some mild fatigue. We did a CAT scan, which showed stable findings. When I say stable findings, there was not much change in the tumor at a month out, and that's typical whenever we treat patients with radiation. It takes a little time for the radiation, for the tumor to respond to radiation. When we saw her back at 4 months, again, she had no breathing problems, no changes in her breathing. Her fatigue resolved. And we did a PET scan at 4 months, and it showed that the nodule from being about 15 millimeters in size went down to 6 millimeters in size. So that's a phenomenal response. It shrunk by over half. And then over time, we continued to monitor her with exams and with scans. And these scans are superimposed, but this is a PET scan at 15 months, and this is the CAT scan part right here, and you can see that we really don't see any evidence of tumor. When we do the PET scan, you just see some low-level glow, and that's low-level activity on the PET scan, and that's just indicative of some scar tissue that formed where we treated. But on the CAT scan, there was nothing there. So this lady did really, really well, and at 15 months out, she had no problems with her breathing, no changes in her breathing. And I went on to continue to follow her, and she did quite well a few years out from treatment without any evidence of recurrence. So these are the typical patients that I see for lung cancer that we treat. And again, just to kind of drive the point home of how conformal SABR or SBRT is, when we do a more conventional radiation, again, anything that's in the beam tract is going to get dose of radiation. So this lung is getting really a high dose of radiation, risking a lot of problems with breathing. With SBRT or with stereotactic treatment, it's a lot more conformal. A lot of the normal lung is being spared of radiation and less risk of causing problems with breathing and side effects. So that's really a critical component of these advanced techniques. The other thing just to talk about with these advanced techniques, we're able to treat tumors that we really would never treat, or we would treat and have a lot of problems with side effects. This is an example of a small nodule next to the aorta in the lung. And with our advanced techniques, we can kind of treat this area, limiting dose to the spinal cord, limiting dose to the big blood vessels and in the aorta, in the thorax. Another example of a nodule. This nodule is in the right lung. And again, this is the heart right here. It's abutting the heart. With the older techniques, this whole area would have got a significant dose of radiation. With the newer advanced techniques, we can bend the dose of radiation around the heart. So again, another example of these techniques allowing us to treat patients that we would not have in the past. So in conclusion, these advanced radiation techniques such as SBRT and IMRT have allowed us to be more precise with the delivery of radiation, resulting in improved cancer control and outcomes, less side effects, and a lot more convenient with reduced number of treatments. We can deliver radiation in days versus weeks. So, I think the field is continuing to evolve and advance, and I think we're only going to get that much better with the years to come. So with that, I conclude my talk, and I'll hand the reins over to Dr. Horne, I believe.
Thanks, Tom. All right, so I'm going to be talking about something very different. What I do is a lot of work in the pelvis and in pelvic cancers, specifically in cervical cancer. We have to give a lot of radiation the way Dr. Colonias was just describing with many of those techniques, but we also have to give radiation from the inside out to try and split the difference between curing the cancer and the likelihood of doing harm. So that technology has also come a long way over the last 15 or 20 years. So I'm going to go through some of the advances that have happened over that time frame and things that have been more recent that we've implemented over the last few years. So just for a little bit of background, cervical cancer is the 8th most common cancer in the world. It's the fourth most common cancer in women. It is a lot less common in developed countries because we have well implemented screening protocols and also now vaccination against HPV, which is the virus that causes most cervical cancer. A recent report out of the UK indicated that with a widespread vaccination protocol, the incidence of cervical cancer has dropped by a third already. So that's really good news. But there's still a lot of work to be done in a lot of other parts of the world. In terms of treatment for cervical cancer, very small cervical cancers can be taken out surgically, and that's typically all of the treatment that would be indicated. But for any cancer that's larger than about an inch, inch and a half, they end up usually not going through surgery and being treated with radiation because they would end up needing radiation after surgery anyway to attain an acceptable cure rate. And so there's multiple aspects of the treatment for a cervical cancer, including external beam radiation, like Dr. Colonias had discussed, chemotherapy that helps make the radiation more effective, sometimes even immunotherapy, which is a new class of drugs that helps the body's own immune system fight off the cancer, and then the brachytherapy, which is the internal radiation treatment, typically given in 4 or 5 treatments over the space of a couple of weeks, so that we can give enough radiation into that tumor to make sure that it goes away and stays gone. And so the rationale for that is that the cervix is surrounded by a number of other organs in the pelvis, including the bladder, the rectum, and parts of the intestines. And they all each have their own specific tolerances to radiation, beyond which they start to have problems, which we obviously want to avoid. And so you can sort of toe that line by giving some of the radiation from the outside in and then the rest of the radiation from the inside out, so that you can achieve all of your goals. And so the question of how it's performed, it requires putting catheters for a radioactive source into the cervix and uterus, and other catheters up against the cervix inside the vagina. The technical terms for these are the tandem, and that's the thing that goes inside the uterus, and the ovoids, which are the things that go up against the cervix. So in the top right, you can see that is sort of a caricature of the tandem, the middle straight catheter, and then the ovoids are the two sort of cylindrical shaped objects. And those historically were filled with radioactive seeds that were then put inside the patient and left there for about 3 days, which was not great. But the goal was to deliver enough radiation to, again, get rid of the cervix tumor. And so these are some actual pictures of different brachytherapy applicators that used to be used. We don't really use these anymore, but these were groundbreaking at the time that they were developed by the physicians who put a lot of time and effort into them. These are some more modern applicators. You can see they're now made out of plastic. That actually helps quite a bit because metal can't go into an MRI. And MRIs give us really nice pictures. So sometimes we actually do an MRI during the treatments, and I'll show you some of that in a little bit. And so just like external radiation treatments used to be planned on X-rays, which was kind of crude, that's exactly how this was also planned in the past. And so there were estimations based on the positioning of these applicators, these tandems and ovoids inside the patient, as to where the tumor might be and where the extent of the tumor might be and where they wanted to try and get all of the radiation to. On an X-ray, as you can tell, you can't see a whole lot. So all of this is based on sort of surgical data, but it was very rudimentary. And so clearly there was a lot of room for improvement, which led to three-dimensional based planning with CAT scans so that we could better evaluate sort of how all of this is done. At the same time, we stopped loading these devices with radioactive seeds and admitting patients to the hospital for a few days. It all became an outpatient procedure that happened over the course of hours instead of days. So that also really helped in terms of the side effect profile of the treatments. And so we have been using image guidance, i.e. CT scans, to improve on the accuracy of these treatments in terms of defining where all of the radiation is going, and also the safety, because now we can see the internal organs with a lot more clarity. But there are also some barriers like the logistics of getting a patient to a CAT scanner or an MRI scanner, the cost of implementation, the staffing, the expertise. So it's not broadly available across the world at this point, but at least in the United States, that's kind of the new standard. And the rationale for the transition is kind of what I just mentioned. There are some other barriers that exist at this point, like staffing and expertise, but also in an era where you have multiple options for what to use. How do you know which set of equipment is maybe the best? And we still have some kinks to work out in the process, but it's come quite a long way. And there are some other sort of benefits, like making sure that everything is where it's supposed to be, because you can't really tell on an X-ray. Did you get it in the right spot? And then also making sure that you're accurately defining your target. So here's a couple of MRI images. And so this long black right here, this is that tandem that's supposed to be inside the uterus. And this oblong gray shape right here is the uterus. And you can see the tandem has actually gone out the back wall of the uterus. This is the bladder right here. And here you can see it was replaced. And so now it's in the middle of the uterus. So this was initially put in incorrectly because it's hard to see when they go in. But if this was planned out on X-rays, they would have had no idea. They would have gone ahead and treated, and they potentially would have exposed the internal organs to more radiation than was intended, and maybe not given enough radiation to the tumor. Here's another image of a misplaced tandem. You can see that this little bright strip right here, that's the endometrial canal, and the tandem is supposed to go up into that. And this is the tandem here. You can see it cuts right across. So it went through. And again, based on an X-ray, you'd never be able to tell. Some other benefits of using image guidance. If the tumor is shrinking, perhaps you can actually reduce how much of the patient you're exposing to radiation during these treatments, which then leads to potentially fewer side effects, because if you're treating less volume, then maybe you're exposing the other organs to less radiation as well. And so this is a really nice cross section. Again, this is a CAT scan, and this is cutting across the patient. This is the tandem inside the uterus, and this red line right here is, the prescription of radiation. Sorry, the thin red line is the prescription of radiation, and the thick red line is the target. And so based on the old way of treating on an X-ray, this thin red line would have been the radiation exposure that was delivered to the patient. And you can see this turquoise outline right here. This is the colon. So the colon is getting exposed to a lot of radiation here. But if you can adapt to what you see on your three-dimensional imaging, you can say, okay, the target is actually quite a bit smaller, so let's shrink this down and only treat the target. And you then expose the colon to a whole lot less radiation. So there's a safety aspect to this as well. Again, your prescription point could reside in another organ like the bladder, so you can pull away from that so that you're not exposing the patient to additional radiation that may not be helpful and could be harmful. And so I've shown a couple of different images of both CT and MRI imaging. And so MRI is actually the direction that we've moved most recently in the last few years. CAT scans tend to overestimate the size of the cervix and the cervical tumor, whereas an MRI gives you really crystal clear imaging to be able to say what is actually tumor and then what is maybe connective tissue surrounding the cervix. And so these are images from the same patient, and you can see that there's this big area right here. This is the bladder. It's filled with some contrast, so it shows up nice and bright. And this area here, this is the cervix. And so you might say that this whole thing is maybe the target based on a CAT scan, because that's sort of what it looks like. But on this MRI, maybe more like just what's outlined in white here is actually the target. So you can, again, shrink your volumes to get similar cancer outcomes, but fewer side effects. And here's another really nice image. So in red, this would be what you might think the target is based on a CT, and in turquoise, based on this MRI, this is actually what you're saying the target is. And so you can see it's a much smaller volume, which again leads to fewer side effects for the patient when it comes time to get through the treatment and enter survivorship. There are still some limitations to having this available. Having knowledge of what your target looks like only gets you so far. Say you have an oblong or an eccentric tumor, because sometimes the cancer spreads into the ligaments that are attached to these organs in the pelvis, or maybe it invades the bladder or the rectum. You may still be limited in how much radiation you can safely deliver, or if the tumor is very large. And so that's led to one of the other very recent advances in brachytherapy for cervical cancers that involves the addition of some needles that are also radiation catheters. And that allows us to sort of extend the radiation coverage in one direction or another to be able to treat things like an asymmetric tumor without overly exposing the pelvic organs to radiation. And so on the left, these are what those traditional brachytherapy applicators look like. And the radiation dose distribution around it tends to be very symmetric. And you can't do a whole lot to modify that. You can do a little bit, but not a ton. And so the newest iteration of brachytherapy applicators have slots in them, essentially, where you can put needles that run through the applicator that then can go into or around the cervix. So again, this black bar, this goes into the uterus, and this ring-shaped applicator, these are those ovoids, they go up against the cervix, and these slots here, all of these little holes, are places where a needle could be placed if you needed to get the radiation extended into that area. So these needles would advance into or around the cervix to create better coverage of the tumor without having to create a symmetric radiation plan that then exposes other organs to more radiation than you would necessarily want. So here's an example of that. Up on the top, this is as if the brachytherapy plan was created with one of the traditional applicators. You can see the radiation dose distribution has this kind of pear shape, which is how it looks when everything is loaded in the traditional manner for a treatment. But you can see this dotted red volume here, that's the target. And so there's a lot of the target outside of this solid red line, which is the radiation, this solid yellow line, which is the prescription radiation dose. So obviously we're missing some of the target, and we're also, you can see here, giving a decent amount of radiation to the bladder here. Up here, this is the colon. Oops. So maybe we can do better. And in this, on the bottom row here, this little dot and this little dot here, which are these white lines here and here, those are needles that have been advanced up into the cervix. So they are catheters for radiation. You can see that the radiation distribution has gone from being this very circular distribution here to more of an oval here. So it's more conformal to the target. You can see it's no longer a pear shape. It is kind of sculpted to the target. And what that means, we're getting better coverage of the tumor, which means potentially better control of the tumor, better likelihood of sterilization, but also potentially fewer side effects because we're exposing the other organs to less radiation. And then from treatment to treatment, you can adapt as the tumor shrinks to again, better harness that therapeutic ratio of risk versus benefit. There are still some issues. It takes a long time to do this. It takes about 4 hours from beginning to end. Fortunately, the patient is under anesthesia the entire time. During that time, the patient can cough, they can twitch, they can kick. That can cause the applicator to move, which potentially changes how the radiation distributes inside of them. They have a catheter in their bladder during the whole thing, but the bladder can fill up a little bit with urine. So maybe there's some uncertainty in how much radiation the bladder is actually exposed to. Same thing with the bowel. A gas bubble can move through during that time frame. So there are still some shortcomings. If we could do this in an hour, perhaps we would eliminate some of these uncertainties, but it does take a lot of time to get through. But that leads us to our future directions, reducing the amount of radiation we give to some cervical cancer patients and maybe getting the same cancer outcome with fewer side effects, increasing the amount of radiation we give to other patients who maybe didn't have a very good response to the initial phase of external radiation. And like I said, now some patients get immunotherapy. We don't really know how that interplays with everything, but could have an impact on how we do things over the next 5 years or so. We implemented MRI-guided adaptive brachytherapy, which is kind of what I just went through in 2019 at West Penn Hospital. The amount of patients we're seeing who are getting brachytherapy has gone up 60% over the last decade and a half. Patients do travel really far. The average distance is about 35 miles, so a large proportion of patients are driving even further than that. So it's become a really critical component of the treatment at West Penn. We've got a really robust gynecologic oncology team. There's 6 of them. They're about to add a 7th. So we're very busy taking care of the cervix cancer patients in Western Pennsylvania. This is a very recent example, just as a last one. I thought this case was really interesting. There's a couple of things that could complicate treatment. So you've got the CAT scan on the left and her MRI on the right. And so this is that tandem that's inside of her uterus. These are calcifications inside of a fibroid, which is a benign tumor that grows inside the uterus. And she actually has what we call a bicornate uterus. Her uterus splits into 2 as it goes up, which is pretty rare. And so you could actually go either way inside of her uterus, but you wouldn't know unless you had image guidance to be able to see that. But what you can see here in yellow or green is what on a CAT scan I might have defined as the target. So here, all of this. And then on MRI, you can see that it's actually quite a bit smaller. This black sort of ring, that's actually her cervix. This big black thing up here, that's the fibroid, that benign muscular tumor. And this is the other part of her uterus over here. So you can see that the overall size of the target is different compared to on CT and MRI. On MRI, it actually extends up a little bit further, and I would have cut it off a bit lower on the CAT scan, not knowing, again, the way that split in her uterus kind of affects her anatomy. So really important, but really nice that we're able to deliver this cutting-edge care to all of our patients. Thanks. And I think with that, I'll turn it over to Dr. Renz, who's going to talk more about the implementation of MRIs in what we do at Allegheny General.
So my name's Paul Renz. I'm one of the attendings at Allegheny General. I'm going to give a brief presentation on our fancy equipment down at AGH called the MRI Linac. Brand name's called the Electa Unity. Listening to the really good presentations by Dr. Colonias and Dr. Horne, I kind of put together some different themes of kind of advancing imaging and use of MRI for treatment, but where the MRI Linac, which I'll explain more in detail through the presentation, really comes in is on the back end of treatment. Dr. Horne did a really nice job explaining the uncertainties of treatment when you're giving it, when you're actually delivering the radiation. And what the MR Linac actually gives us is the ability to custom the radiation, but follow it in real time and make sure that the treatment that we're planning to deliver is delivered accurately. So just an overview of the talk. I'll give a little bit of history. There's some crossover and overlap with what Dr. Colonias already mentioned. We'll go through the process of radiation on the MR Linac, the benefits and some examples, as well as some clinical trials that we're doing. So here's some of the overlap. X-rays have been used to treat cancer since the early 1900s. Dr. Colonias is probably the only one old enough to remember that, but through advances in imaging, we have improved quality, precision, and efficacy. So similar to Dr. Colonias' slides from his residency, this 1950s and 1990s fluoroscopic 2D planning, which you could see in the top right corner, was basically planned based on an X-ray. Through the 1990s and early 2000s, we get CT-based planning where you're able to, if you look at that kind of yellow circle, shrink the representative treatment area. And now through a lot of advances in physics and imaging, we have the combination of MRI and radiation delivery at the same time, where we're able to offer even more precision, basically shrinking the area we're treating, minimizing toxicity, and allowing us to go to higher doses. So here is a picture of the MR Linac, very similar to the one we have. This is kind of a stock photo. As of today, based on what I could there's a lot of these being installed, but right now I think AGH in the US is one of 16 US-based sites. There's approximately about 50 worldwide, but very novel technology, only one in the region, and very lucky to have it. So the process of MR-based treatment is very similar from the start to all other radiations. We do our consultation, we evaluate the cancer, we evaluate the indications for treatment. Then we move on to a process called the simulation or the planning or the mapping. And that's basically a CT scan with positioning devices like Dr. Colonias had showed, which we then take that kind of process and do computer-based modeling of the radiation, delivering the dose to the tumor and trying to avoid the normal tissue. And then we move on to the treatment. And when we deliver a radiation treatment, conventionally, we do a CT scan or an X-ray to confirm the position of the tumor to deliver the treatment as we intended. But once we start the treatment, there's no further monitoring. So during that 10, 15-minute process, patients can move, they can cough, they can have organ motion that can move organs into the area that we don't want or move the tumor out of the area where we're intending to treat. Those are some of the issues that the MRI fixes through things called adaptive planning, which is because of the extra imaging precision of the MRI, we're able to use that imaging and software to then custom a radiation plan each day based on that tumor's anatomy and organs around it. We're also able to monitor motion. People are breathing, bowel and stomach is moving through peristalsis. And there's different organ motion internally that we're able to evaluate and account for. And then we're able to real-time monitor that through the treatment. So I got some pictures of that. And that's where kind of all the benefits kind of come in. Yeah, there's better image resolution, but the real things are that we're able to provide that adaptive treatment planning, and that's that custom radiation plan based on that tumor position and anatomy on that day at that given time. We're able to then monitor and evaluate tumor motion. And because of all that precision, we're able to take what was previously 6 weeks of radiation and condense it to 5 days, and that's the process of radiosurgery. So here's an example of the onboard imaging resolution. On the right is a CT-based treatment. This is our kind of bread and butter traditional radiation. You can see that it's quite, blurry, where on the left is an MRI-based treatment. This is a pancreas radiosurgery treatment where you can see how you can see the bowel around the tumor. I don't know if you guys can see my cursor here, but you can see the bowel here, the liver, spleen, kidney, and everything around it very crisp and clear. And on the right-hand side, you can maybe make out the tumor a little bit. You can see the bone, but it leaves a lot to be desired. So through that extra imaging resolution, there's also advanced software where we can account and reshape the radiation. So on the right here is an example of a prostate radiosurgery treatment. This is 6 different treatments through his treatment course, or actually 5 treatments in his initial planning session. And you can see at the top in the yellow, I'm colorblind, so it may be yellow, maybe yellow-green, who knows what exact color it is, but this bright yellowish color is around the bladder. And you can see the bladder filling based on different positions through different time intervals is much different, even though the patient was given the same instructions to fill their bladder in the same way. Behind it in this more teal color, you can see the rectum, which is the 2 organs we're trying to avoid in a stereotactic treatment for prostate, the rectum and the bladder. You can see the differences in rectal filling, and this black kind of dots within the rectum are air and stool that is moving through. You can see these position changes closer and farther away from the tumor based on those particular days. On a normal radiation treatment, we're not really visualizing that. And those organs are getting extra radiation on those days when we're not visualizing that. The beauty of the MR is we're able to account for those changes and move the radiation around those differences in organ position. And then while they're getting treatment, we're able to monitor them. I hope that this is playing in the movie like it looked like it was for me. But this is an actual pancreas radiosurgery treatment. And you can see at the top is their heart beating. You can see their diaphragm moving as they breathe. You can see my shoddy camera work also kind of moving the whole screen on the left. But the area in green is the tumor we're actually treating, and the organs moving around it we're able to watch in real time while they're getting treated. So some examples would be a prostate radiosurgery treatment. This is an example of an MR-based prostate radiosurgery where we're able to condense 28 conventional fraction treatments into just 5. This is an example of a pancreas radiosurgery treatment where we're, again, taking these longer, less efficient courses, condensing them based on the very nice imaging characteristics, where you can see how close these loops of bowel that are in this kind of like beige color are what we're trying to avoid. You can see how the radiation dose is just sculpting right around those. This is an example of a liver tumor treatment where this moves a lot when you breathe. They're very difficult to visualize on conventional CT imaging without contrast. You're unable to give contrast on a day-by-day treatment because it would be too hard on the kidney. So MR gives you very nice imaging resolution to accurately localize the tumor and then deliver the treatment. But still, we need more data and research on these. There's lots of publications coming down the pike on this technology, which is quite new. At Allegheny General, we're doing some of our own work. This is one of my mentors, Dr. Kirichenko's work with nanoparticle-based contrast agents and hepatocellular carcinoma stereotactic treatment. And another trial we're running is, among others, is a soft tissue sarcoma using MR-Linac, which is very well visualized on MRI-based treatments, and it gives us that extra precision to avoid the organs of risk around the tumor. And so that's all I really got, a quick overview of it. Happy to field any questions.
Great, thank you. At this time, we still have a few minutes left. We're going to wrap up at 7 p.m. But if there are any questions that folks have for the presenters, if you could please go ahead and type those into the Q&A session. I don't see any questions there at the moment, but I'll pause for a moment to see if any questions come in before we close. Okay, I'll come back to the questions in a minute, but I'll go ahead and do the wrap up and we'll come back to it in a moment. So we'd like to thank you for attending our Ahead of Cancer lecture this evening. Please continue to join us monthly on our Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, please check back on the AHN YouTube channel, www.youtube.com/Allegheny Health Network for a full recording, and this will occur in about 1 week. This video, as well as other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please feel free to call the Hope line at 412-578-4673 to schedule an appointment. Let me just check if there are any. Oh, there's some questions that have come in. Okay. First question for the panel is, how often do you see tumor changes for each treatment? Do they change a lot? I guess between treatments might be the question. I guess we're not imaging necessarily between those, but go ahead, Dr. One of the physicians. I'm not sure who would like to take that one.
Dr. Renz, you could probably take that one.
Yeah, so that's one of the kind of questions that's kind of very MR Linac centric. Also with the brachytherapy, there's a lot of kind of changes, but it depends on the tumor type. There's some tumor types that shrink slowly over the course of months, and then others that shrink more abruptly over the course of days to weeks. So if you have one of the tumor types like a head and neck squamous cell cancer or a lymphoma that shrink very fast, you can see tumor changes through treatment. That's one of the beauties of the adaptive planning that you see with the MRI-based brachy or MR Linac, where you can, as the tumor is shrinking, shrink the treatment volume and treat less normal tissue around it. There is other tumors like colorectal tumors or some more of our slower growing tumors that will shrink less through the treatment. You'll see less tumor changes until you get months out and repeat scans. So that can be a yes and no question. It depends on the tumor type. But yeah, we do a lot of times see some changes through the treatment.
Okay, great. Thank you. Next question. Is MR-Linac treatment only for certain cancers at this time?
So that's a good question. I kind of I think left that out in the treatment itself. So it's not for specific types of tumors. It can treat, in theory, any types of tumors, but there's certain tumors that will benefit more from the technology. Upper abdominal tumors are very hard to see on CT-based imaging without contrast. And there's a lot of organ motion with your diaphragm moving and bowel moving. Bowel moves on a day-by-day, minute-by-minute basis. So how do you account for that? That's what the MR and the real-time imaging and adaptive planning really works well for upper abdominal tumors. Things like a prostate cancer work really well because prostate is seen really well on an MRI, same with the sarcoma. So there's a lot of kind of certain tumor types that are more ideal for it. And then there's others that are kind of less ideal. An example would be what Dr. Horne had talked about with some of his brachytherapy-based treatments. Brachytherapy is a very technical, high-dose treatment, and MR wouldn't replace that in certain diseases like cervix, where that kind of technology is better than the real-time monitoring on an MR-Linac. So it kind of depends, again, on the tumor type, and there's certain types that are better suited to it, but it could be used for any type of tumor, just depending on the situation.
Okay, great. Next question. Are there any plans to expand the MRI technology to the community?
So Dr. Colonias is our clinical director. That'd be a good one for him, but I can answer it as well. No, I think we use MRI technology for treatments across the board where we're using them to aid in our planning. As a template, we get diagnostic MRIs to help plan out where we're treating. The MR-Linac is a very fancy technical machine that is unlikely to be rolled out to the community other than the main academic centers, just due to cost and staffing and upkeep that it requires. But and same goes with brachytherapy. That's usually located in high volume academic centers like Dr. Horne does at West Penn. So those things will always kind of usually stay consolidated at a certain locale. But there is use of MRI and other forms at community centers, but in the sense of doing adaptive planning, MRI guided brachytherapy, those are usually going to be localized at the academic centers due to cost and staffing.
And I can add to that a little bit. Just, from a standpoint of the MR-Linac, it requires a lot of technical and clinical expertise. And, having it at really the academic center and having, a team of people really utilize it, they get really good at it. Our goal at AHN Cancer Institute is to try to give as much cancer care in the community, but there's certain specialty techniques such as this, which right now is best as we master it at the academic center. Future, who knows, there may be a role for MR at some of our regional centers, but for now, as we're learning the craft and building that skill set, it's really paramount that we have it at AGH. But the future, our goal is to deliver care at the community also. So we look at both of those and we try to as our goals.
Okay, great. Next question is, would there be a situation where you might get IMRT, SABR, brachytherapy, and MR-Linac as a combination treatment is a question.
I can field that one again. There's a lot of combo treatments like Dr. Horne alluded to where we do a certain amount of radiation, treating a bigger area from the outside, and then combine that with brachytherapy to deliver a higher, more conformal dose to a smaller target internally. So that we do a lot of combo treatments: cervical cancer, prostate cancer, are kind of the poster child for that. There is also the state of what's called oligometastatic disease, where people have a few limited metastases that we will treat with either surgery or ablative radiation, like stereotactic radiosurgery, and in combination with those other radiations. So those would be very advanced cases that rely on effective systemic therapy and multiple combination treatments for local therapy. So there is some times where like there would be this big combo deal, but it wouldn't be the most typical.
And that sort of addresses one of these other questions about radiation not taking after the first go around. Sometimes we use brachytherapy for reirradiation. Sometimes the MR-Linac is a better, more elegant solution. So there is often an opportunity to reirradiate in a lot of circumstances with one of those more advanced modalities.
Okay.
And also having a dog really helps.
Exactly. He's adorable. Okay, well, I think we're getting close to 7 p.m. We want to be respectful of everyone's time. We have a few questions left unanswered. Does anybody want to answer any of those quickly, or do we should go ahead and wrap up, I think, probably.
I can answer them quickly. The first one,
Sure.
from success rate, that's hard to answer because it varies based on the disease that we're treating, the tumor biology, the patient-specific factors. So like a general success rate is really hard to give a specific answer to. So unfortunately, I don't think I can really answer that one well. But I think I put my email after the slides. If anyone wanted more specific answers, I'm happy to kind of like converse about more specific situations. But from a glioblastoma standpoint on the MRI-Linac, there's actually some very interesting data showing adaptive planning being beneficial for glioblastoma on MR-Linac. It's a lot of stuff coming out of Toronto and Canada. Among others, we're starting a program where we're doing more of that through one of our CNS leads, Dr. Rodney Wagner, is doing some really nice work in that space. And there is a benefit that we're trying to quantify. It's an active area of research on the MR-Linac. And there's ongoing clinical trials trying to quantify that benefit, which the early data is showing a signal where it could be potentially beneficial for glioblastoma.
Okay, great. Well, thank you for those responses. And I wanted to thank you guys for the great presentation. And we wanted to thank all those who attended this evening, and have a wonderful evening.